Good morning for those who have attended this. I will talk about drug-induced liver disease, pathogenesis, and treatment options in the next 40 minutes or so, I hope. And I just want to clarify and define drug-induced liver injury with respect to this talk is focused on acute liver injury, which is due to a medication taken in a therapeutic dose, which is the event is not explained entirely by non-pharmacological action of the drug. It's often referred to as idiosyncratic drug-induced liver injury. I try and stick to the word drug-induced liver injury as it's quite difficult to separate out in any other circumstance other than overdose, whether you can talk about intrinsic injury versus idiosyncratic injury. So I will just stick to drug-induced liver injury. I'll talk about the premise of what we are addressing today, what the risk factors for drug-induced liver injury are, the pathogenesis as I see it in humans, and evidence base for interventions. It starts with Aristotle, about 450 BC. Greek culture was thriving, and there was a way of putting across arguments, understanding, and this is one of the styles which was called rhetorics, a persuasive argument. This is one of the rhetorics of Aristotle, who was the major thinker at the time. What he says is that none of the arts theorize about individual cases. Medicine, for instance, does not theorize about what will help to cure Socrates or Callias, but only about what will help to cure any or all of a given class of patients. This alone is the business. Individual cases are so infinitely various that no systematic knowledge of them is possible. The point he's making is that we talk about individual medicine, precision medicine, but it's quite difficult because we do not know what makes an individual. So a small proportion of individuals who have received a drug for an appropriate indication many a times in an appropriate dose, as we understand it, will still get adverse reactions. One of the key problems with drug-induced liver injury is that preclinical toxicology is not picking up many of these. So only time one identifies this once they come into clinical practice or used by a large group of people. And that is why it's often called idiosyncratic drug-induced liver injury. The key reason behind this is that animal models aren't really reflecting, obviously, the individual we are talking about. Here is one of the latest results, which has come from one of the pharma company, comprehensively going through their preclinical toxicology. There were 77 candidate drugs here, and liver was the most common target organ toxicity, explaining nearly 2/3 of their organ toxicities. And these are selected based on histopathological changes. So these are not just toxicity loosely referred to. You can see both in rodents as well as non-rodents, it's a commonest one. And then if you look at the drug development, 72% of these particular candidate drugs, despite showing their toxicity, were taken to the next stage, which means that even those who are conducting these experiments don't have a confidence that those signals are really relevant to humans. And that is because I think is the individual response and difference and what makes a human a human. Risk factors of drug-induced liver injury, I have grouped them as drug, host, and environment. This is a standard triangle in most of the epidemiological observational studies that you see. And with drug, dose, although we are excluding overdose, we are including only therapeutic dosage, a daily dose within the therapeutic range still determines likelihood of a particular drug being associated with hepatotoxicity. I'll give you some evidence for that. Hepatic metabolism, biliary excretion, or other two factors have been reasonably consistently shown to be associated with drug being related to injury. In terms of environmental factors, fatty liver or chronic liver disease in studies have demonstrated to be one of the risk factors to increasing susceptibility to drug-induced liver injury. But the host factors are the key factors which aren't really seen often in the same way in animal models and can't be replicated often in vitro models. That is why the toxicity experiments do not really reveal rare adverse reactions related to the liver. So there is data on age. It's one of the factors which come up. If you look at the large data sets, ethnicity, there are factors, but I would really focus on genetic polymorphism today. And all these factors combined together eventually set out a pathogenetic pathway to drug-induced liver injury. This is one of the database studies, comes from US, where they had a cohort of people identified through liver enzymes, almost 5,000 people with suspected NAFLD. And they had excluded standard common diseases where the laboratory tests or serology were available. And there are two sets of control groups, different ones. And you can see there is some difference between the cases and controls in age, gender distribution, degree of liver enzymes, obviously because NAFLD was picked up based on the liver enzyme elevation, and presence of type 2 diabetes often related to non-alcoholic fatty liver disease. And there were a number of top used drugs which their risk factors were looked for, which included comoxiclav, isoniazid, nitrofurantoin, minocycline, trimethoprim, or cotrimoxazole, ciprofloxacin, levofloxacin, azatap, azithromycin, cefazolin, all of them are antibiotics. We can talk about why antibiotics seem to come up, because these are short-term medications. It also highlights the significance of drug-induced liver injury. These are not really necessarily a chronic drug usage. And the diclofenac is one of the key drug to understand certainly mechanism. I've used it as a paradigm, but this is the list of the drugs they had. And they found that incidence of drug-induced liver injury was significantly higher, fourfold higher in people with non-alcoholic fatty liver disease compared to both the control groups. But there wasn't really any data to show that severity in these people in terms of drug-induced liver injury and their outcome was much higher. Daily dose, I mentioned about it. So if you go through a huge number of drugs which are approved by regulatory authorities and picked up 230 top generic drugs prescribed based on the prescription volume in the US, and then group them daily based on the daily dose, less than 10 milligrams, 11 to 49 milligrams, and more than 50 milligrams per day dose. And then go through the reports of drug-induced liver injury. You have got significantly higher reports of the drugs used more than 50 milligrams per day. This is not overdosing. This is a therapeutic range of the drug being more than 50 milligrams per day, at a higher risk of being associated with reported jaundice, high risk of liver failure, high risk of death and transplantation, which highlights that overall dose itself, even when you call this an idiosyncratic drug-induced liver injury, might be a risk factor. Liver contributes to a number of drugs hundreds of drugs which are metabolized, even when the target of the drug is not really liver or GI system in any way. And this is, again, a database related research where 200 plus commonly prescribed drugs from US, and go through the literature and find out how many of them had more than 50% of their metabolism happening in the liver and biliary excretion being contributed by the liver. You can see that significantly of them had raised liver enzymes over threefold, high risk of liver failure, high risk of death reported in association with them. So these all narrow down the possibility that adverse reaction in general is related to liver's involvement in metabolism of the drugs and its clearance. Now, coming to the pathogenesis, I told you that I'll pick up diclofenac as this is something which we primarily took as an example at the time to understand the mechanism in humans. So most of the data, probably almost all of it today, is based on human studies. We've got some data on in vitro models. This is a young lady, I think she was in her 30s, had a kickboxing injury. She took diclofenac, and as you can see, she developed a clear-cut liver injury. She wasn't on any other drugs. And when diclofenac stopped, it improved. And so what happened in this lady? If you think of the putative pathogenetic pathway, is that drug, as I mentioned, commonly forms a metabolite. Many of them are stable and they get excreted. And within the period of it being in the system, it brings about its action, whether it's in the liver or elsewhere. But small proportion of drug gets converted into reactive metabolite, and it is common for reactive metabolite form with most drugs, although I'm not really talking about biologicals. We'll come to that in a minute. And there is always a pathway within the body to bioinactivate this and then get them through to a safe route outside the body. If these are not converting to reactive metabolite, many of these drugs can cause cell stress in different ways, either through mitochondrial effect or endoplasmic reticulum effect. So cell stress has the similar effect. But proportion of individuals who are by genetic variant might be metabolizing through alternative pathway, and they might generate more reactive metabolites than expected, and that itself might, in a small proportion, lead on to drug-induced liver injury. When you have got accumulated reactive metabolite, they might bind to cellular proteins and form covalent adducts, or they might bind to circulating proteins and form covalent adducts, and that results in cellular dysfunction, and that itself might cause drug-induced liver injury. Or covalent adducts might be presented HLA molecules, and adaptive immune response might take over, and immune mechanisms might lead on to drug-induced liver injury. For each of these, there are always mechanisms, pathways, which help cell to, or the organ to, or the organism to recover from it. You have got injury directly related to reactive metabolite, the cytoprotective genes which get upregulated. You might really recover it before you clinically manifest with injury. Same way, if protein dysfunction, cell might die, but there are abundance of cells, or there is a capability of new cells being formed, and that might again recover without really developing into drug-induced liver injury. Same way, you all know that small number of patients will have raised liver enzymes but do not ever get liver injury, even with the continuation of the drug. It might be due to immune tolerance, where you don't manifest clinically liver injury. And even if you get liver injury, you might regenerate and then you may not really recognize it clinically all the time as significant. Let's talk about proximal events, as I mentioned. This is related to diclofenac. If you take that as an example, it gets metabolized through what is a phase 2 metabolizing enzymes, UGT2B7, and it forms acyl glucuronide. But UGT2B7 forms acyl glucuronide, and the acyl group makes actually glucuronide, although it's called phase 2 metabolizing enzymes. It itself a reactive metabolite. And that gets cleared through ABCC2. It's one of the transporters into the bile. And when too much metabolite accumulates, it can go through ABCC3 and get circulated and eventually get excreted. In the same way, CYP2C8, one of the cytochrome P450s, can also form a different kind of reactive metabolite. It's 5' hydroxydiclofenac. And as I mentioned in the hypothesis, these metabolites can accumulate in an individual who have got genetic variant of overactive of UGT2B7 or underactive CYP2C8. And eventually, you might really generate too much reactive metabolite. And if you have got a upregulated or overfunctioning UGT2B7 due to genetic polymorphism, you've got 8.5-fold more likelihood of developing diclofenac. In the same way, the transporter is not really functioning because of a underactive variant. You've got 5-fold excess risk of getting drug-induced liver injury. And we showed that this might be contributing to the mechanism. We took a group of people who had diclofenac hepatotoxicity, another group of people who had diclofenac for a long term, did not get any hepatotoxicity, and healthy controls, and demonstrated, first of all, the polymorphism that I mentioned, which relates to variants in UGT2B7, ABCC2, were more often seen in people developing diclofenac toxicity compared to both the control group. We also showed that this is one patient who developed diclofenac-induced acute liver failure. You can see are forming adducts within the liver. We also took serum from these 3 control groups and demonstrated that they have got diclofenac-related antibodies, suggesting that they do have diclofenac adduct formation. So overall, we demonstrated that at least in a candidate gene study design, genetic polymorphism, which changes formation of reactive metabolite, as well as their clearance, contributes to drug-induced liver injury. In addition, when there is a subclinical liver injury, you've got either a generation of inflammation or cytokines get released. In addition, adducts also get released. So there is a concept called danger hypothesis, which suggests that immune mechanisms do not really look for self and non-self, but actually look for danger signal. So if there is a subclinical liver injury and you have got a immune environment where you are likely to respond to it, a danger signal will activate that mechanism where cell or an organ or a system recognizes a danger and triggers almost like overactive immune response. So we looked at polymorphisms of IL-10, which is an anti-inflammatory, and IL-4, which can really generate inflammation in Th2 pathway. And polymorphism in these also were increased, associated with increased risk of toxicity. So in one set of cases and 2 sets of control groups, we established this in human way of drug-induced liver injury. Just recapping it, that diclofenac can be metabolized to acylglucuronide, which is excreted through ABCC2. And if there is an overproduction of these or underaction of transporter, then you have got excess reactive metabolite accumulating in the cell, which might really cause subclinical injury, which leads to release of cytokines and chemokines. And that might really tell the antigen presenting cells and immune systems, adaptive immune system, that there is a danger signal. That kind of get overactive and result in overall drug-induced liver injury. This was a time when genome-wide association studies started becoming much better way of identifying genetic signals in association with complex trait. So these are two studies. We have had number of studies demonstrating association with both HLA molecule and a few associated non-HLA molecules, but I have picked up one of the first studies, in fact, the first genome-wide association study in drug-induced liver injury. On the left-hand side, we did it in small group of people compared to most of the genome-wide association studies, but it's a rare condition. We still saw the signal. It shows how strong the signal is. 51 cases of flucloxacin-induced liver injury, 282 sex and ancestry matched controls. We found a signal, which is a tag of HLA B5701. You can see a little star. This Manhattan plot, most of you might be used to know reading it. All these dots, there are about 700 dots in this plot. Each one is a variant, and y-axis is log of p-value. So the higher the dot, lower the p-value, and this one is a tag for HLA-B 5701. On the right-hand side is PTPN22. It's a well-known polymorphism. It's in a non-HLA site. As you can see, a lot of signal in the red, which is chromosome 6, but one on the left-hand corner is the PTPN22 signal, which has been previously associated with a number of autoimmune conditions involving joints, involving bowel, involving pancreas. So this gene in particular codes for majority of cells, both in innate and adaptive immune system. It might be working through a number of mechanisms influencing immune systems and generating a loss of immune tolerance. So this suggests that adaptive immune response is key. And in this study, we showed 80-fold increase in risk in the first set, and then a 100-fold increase in the replication cohort. Then now we have increased the number of cases as well as a control. Number of cases is close to 200 now. Still, this strength of association holds. So how does HLA molecule contribute to drug-induced liver injury? These thoughts were triggered by two patients I had within a 6 months period, way back, I think 2014 or something. Both were patients who had exposure to comoxiclav, presented with acute liver failure, and both ended up with transplantation. And both had HLA DRB1 class 2 molecule related variant 1502, which is not the one we showed in Caucasians, which was 1501. So if you look at how HLA contributes to overall drug-induced liver injury or adaptive immune response, is through the presentation of peptides in this peptide binding group. This is a 2D picture, and I have just marked in color the amino acids in 1501 molecule and 1502 molecule. So they This is a 3D picture in the middle here, and its polarity really shown in a range of colors between blue and red. So the peptide binding is determined by the shape of this peptide binding groove. You can see a crevice here, and shape of the peptide that should fit into this. And pocket 1 here marked is critical, and you can see the shape looks the same and the polarity looks the same. So HLA DRB1 1502 is more prevalent, more common in Asians. Both patients were South Asians, and but the structure of this peptide binding groove, and particularly the pocket and its polarities, are not different. So it's highlights that for South Asians, probably this is a risk allele, and that also points to what the mechanism by which HLA genetic variants can really cause to presentation of adducts and hence drug-induced liver injury. Most recently, this has just come online, March issue of Gastrointestinal. This is another non-HLA molecule, but this is what we call expression quantitative trait loci. These are genetic variants which determine expression of genes. And this one in particular, this is associated with the expression of endoplasmic reticulum aminopeptidase and its function. And that was significantly associated with carmoxyclav drug-induced liver injury. And what does endoplasmic reticulum aminopeptidase to do? And it actually cuts the peptide into a shape and passes it on to be presented by MHC molecule. And then it's much more ready to be identified by T cell receptor and then generate immune response. Again, pointing to a hypothesis that I was presenting, and now I'm more talking about adaptive immune response. If I can recap again, reactive metabolites are formed. They can bind to covalent adducts within the cell, and if it is class 1 molecule, this altered peptide can be presented by hepatocytes, for example, and this can be designed by ERAP2 in the rise, size, and the shape, and that generates CD8 positive cells to be active, and their behavior is altered by PTPN22, and then they really result in cytotoxic T cell mediated injury. That's how class 1 molecules might be influencing, as well as how ERAP2 and PTPN22 fits into this pathogenic pathway. Class 2 molecules have also been associated with drug-induced liver injury. So I mentioned that circulating adduct can be presented as well, and these are two lines of evidences. Both are done in vitro systems. The top graph shows the level of flucloxacillin covalent binding to albumin correlates with proliferative response in vitro system, which means that albumin binding, which is a circulating protein, obviously, is critical in, at least in the in vitro system, cell proliferative response. And the lower panel shows that in individuals, volunteers who have got HLA-B701 carriers, T cells are already have got a genetic environment. Then you present dendritic cells, which are necessary, antigen presenting cells, necessary for class 2 molecules generating T cell mediated immune response. So evidence really, again, supports the putative hypothesis that I set out in the beginning. How strong is the genetic architecture in determining toxicity and how we can use it to improve a system of identifying hepatotoxicity, in particular in drug development. This is the study published a few years ago, which started with a drug-induced liver injury, which was identified in a new drug. And this was investigated using a genome-wide association study. And obviously a small number of controls, and they did not see any genome-wide association signal in this. That is understandable because genome-wide association studies are designed to absolutely, by all means, avoid false positives. So the robustness of the analysis means that any minor signal can't be identified. Anyway, the question was that whether the genetic architecture, which is identified based on drug-specific liver injuries, such as flucloxacin and comoxiclav, are the top two drugs which are in all our experiments, because these are the common causes in UK and Europe as well as US, and that's where most of the studies are based on. But do they have a generic application is the question. So the work was the cell-based work, culture-based work was done by Taka, who works both in Japan and US. He took out 21 donors, created a primary hepatocyte cell culture, and also 5 donors, used cells from them. I think they used peripheral blood monocytes to generate inducible pluripotent stem cells. Then they can differentiate into hepatocyte-like cells, and then you've got an in vitro system. The evaluation of polygenetic scores. So we derived a polygenetic score using the data we had from our previous studies, and then saw whether the cells manifesting high risk polygenetic scores are more susceptible to hepatotoxicity when targeted by the drugs which are not fluclox or comoxiclav. I hope you get the description of the experiment. So created an assay, cell-based culture, and then challenged them with the drugs. And then the graph I'm showing is the viability going down is the endpoint, and polygenic score, risk score, is in the x-axis. So x-axis is polygenic risk score derived from drug other than falsigliflozin, and viability score in the y-axis. And using the polygenic score derived from fluclox and amoxiclav dominated drug-induced liver injury studies, one could demonstrate that polygenic score identify individuals who are prone to develop drug-induced liver injury due to 12 drugs here. And they all work differently. They are structurally dissimilar, but the same polygenic architecture, which looks authentic, is associated with drug-induced liver injury in the in vitro system, which are both, you can see triangles are one culture system. I think they are pluripotent stem cell derived hepatocyte cells, and the round ones are related to hepatocyte culture. Coming to treatment, you have seen adaptive immune response being fundamental to drug-induced liver injury. Even in that in vitro culture, you saw that heavily dominated by drug-induced liver injuries from the drugs, which have been associated with immune mechanisms in genome-wide association studies. This is the one cohort from US acute liver failure group, 361 people with acute liver failure. And they divided them into three groups. 66 of them were clinicians managing the patient thought this was autoimmune hepatitis related acute liver failure. 164 patients who had indeterminate etiology for acute liver failure, and 131 people where clinicians diagnosed drug-induced liver injury. And proportion of these, and if you look at all the three separately, none of them, there was statistically significant benefit from steroid treatment on overall survival. In the contrary, people who had a MELD score more than 40, survival was diminished in association with steroids. So steroid treatment has no evidence-based support, even when you think it's autoimmune hepatitis, at least in this study, once acute liver failure has occurred. So you're not doing any harm, at least, not giving someone steroids. But just want to really point out that there was some difference in spontaneous survival, although this wasn't statistically significant, maybe because of the small samples. But steroids are used and may sometimes be justified in being used when one can't separate out people between what we call a drug-induced autoimmune hepatitis or drug-induced autoimmune-like hepatitis now from drug-induced liver injury of other kind. And this is quite often the case because ANA, SMA aren't really very distinctive tests. Only test we have got for routinely used for autoimmune hepatitis many times is immunoglobulins. In these patients, if you end up having to start steroids, I would say that once you achieve remission, one should withdraw steroids and then follow them up without immunosuppression. And this is data from multiple pooled case series where none of the patient required long-term immunosuppression. And the follow-up is really variable. So even if you had to give steroids because you thought you can't tell this is not autoimmune hepatitis and patient is not in liver failure, you can still withdraw it once remission has been achieved. And there is one study which I was involved in, mainly advising and reviewing some of the data and histology. It comes from China. This is a randomized clinical trial. A significant number of patients involved in this study were from Chinese traditional medicine, and you need to keep that in mind. So they randomized 80 people for open label steroid treatment. 70 of them completed the study. And you can see the skew here, 78% are women, 78% were over 40 years, hepatocellular form of drug-induced liver injury. And I was just saying that a common feature was also that traditional Chinese medicine or herbal remedies contributed significant proportion of these people. And they identified what they defined as chronic drug-induced liver injury, which seemed to be a little bit uncommon in my experience, but they defined it based on American College of Gastroenterology criteria more than 6 months after what they thought was drug-induced liver injury. If the liver enzyme elevation persisted, they called it chronic. And then they gave glycyrrhizine, which is seen as effective treatment in China, plus or minus corticosteroid. And they tapered off. They started with 48 milligrams and tapered off over 48 weeks. And then there was a 24 weeks follow-up after stopping the steroids. And you can see the number of parameters were significantly better. Liver enzymes, histologically, about 30 in one group and 32 in another group had liver biopsy both the times, and there was less activity score, less fibrosis score, and some of the non-invasive markers improved, and they don't really see the significant increase in adverse effects. But this is very small group and a little bit unusual group for the reasons that I mentioned. And acute liver failure management has improved, and this is due to improvement in treatment that we have. So people who have got drug-induced liver injury, this is one of the analysis comes from US. They looked at two periods, 1998 to 2005, and then 2006 onwards. And you can see the 21-day survival has improved just over a period of time. And looking at it, why that might be, it's not due to severity has changed. Hepatic encephalopathy grade is same, INR is same, but more people are receiving NAC. And even in non-paracetamol overdose, they are getting more NAC and they're getting more antibiotics. So these might be an explanation why their survival might have improved. And this is only a randomized controlled trial that we have got. It comes from acute liver failure group. William Lee is the author, and their primary endpoint was overall survival, which wasn't better. But the post hoc analysis showed that if you had got an early grade of encephalopathy before you received N-acetylcysteine, you might have a better transplant-free survival. So if this is as good an evidence you can get that if you happen to see someone imminently in liver failure, coagulopathy, grade 1 encephalopathy is hard to confirm, but if you think the patient has got it, or even if you don't have it, I think it's practically reasonable to give N-acetylcysteine. Prevention is the best cure. Okay, this paper also has just come up, February 2023. This is a randomized, open-labeled, cluster, multinational trial. It's worthy of reading, so I've given you a reference there. I'll just summarize in one slide what they did. So they randomized about 6,000 plus patients in multiple centers in multiple countries in Europe. And they had a panel of 50 variants in 12 genes and related to 41 drugs. So they created a panel of drug gene variant pair. And people who are randomized in a cluster randomized fashion, which means that the whole country was randomized into one or the other group, and a period of 19 months where they followed either standard care, which was just treat them with a drug, or intervention, which is get a result of the variant gene array results, which I have put on the right-hand side, which shows the card they get with a QR code. If you scan it, it'll take you to a website. And this is one of the patients. Patient has an alert on azathioprine, codeine, mercaptopurine, and thioguanine. And then when you go to the details, it'll tell you what the recommendation is, like reduce the dose or monitor increasingly or consider an alternative and something along the line. And they followed that. Other group just was a standard of care and they were not given the test results. Instead, they were just given a card saying that patient is in this trial. And the outcome was assessed by nurses, not the people who are prescribing. And this was a patient-related outcome measure, PROMS. Patient was asked, how did you feel? What happened? So open questions first, and then if they identified drug-related adverse event, this is not purely related to liver number, but the drugs such as flucloxacillin and 5701 pair was there. Similarly, there were pair between warfarin, which one of the drugs which I worked on early on. And as I mentioned, there are 41 drugs there. A number of them are also associated with drug-induced liver injury as well. So the results were that they defined it as causal adverse drug reaction. Causality was assessed by the clinicians based on a standard tool for all events, all organ events. So this wasn't really standard drug-induced liver injury causality assessment, might be a limitation, but overall, they decided causal and only picked up those they called causally associated, which is either probable, possible, or definite association. And clinically relevant ones, they took only grade 3 or 4 adverse drug reactions. They found that the intervention group had 30% reduction in adverse events, which are causal and clinically relevant. And they had on follow-up further opportunity for clinicians to intervene. And if you take those events, then the odds ratio went down, which means they're even more beneficial, which means that if you had it in your bank when you see a patient already, then you will be better off. Remember, it took 7 days for them to get a result. So they took only prescriptions more than 7 days. So there will be, they generally, the authors conclude that they underestimated the benefit. It will be more beneficial than they have identified. And then if you take intention to treat analysis, take every patient and every adverse event, irrespective of all these assessment, again, odds ratio is much better. So that is where I'll stop. I need to thank and acknowledge all my funders and my team. Thank you.